Good evening, everyone. I think we'll get started. It's nice to see you all. Can everybody hear me okay? Yep. Just not? Okay, great. Well, welcome to tonight's Neighborhood Health Series. I just want to give a quick thank you to Clark County Credit Union, who is our presenting sponsor. Clark County Credit Union has been our sponsor for many years, and all of the dollars that they contribute to the Neighborhood Health Series goes directly to our student scholarships. Just a quick note, this is a very special week for Roseman. It's Roseman's week of Thanksgiving. It's one of our biggest and most special weeks throughout the year when we raise funds for student scholarships. So if you're interested in contributing to a student scholarship, please go to givetoday.roseman.edu. So all of those dollars raised go directly to student scholarships. Just a couple housekeeping items. I am recording this session and this will be posted on the speakers.roseman.edu website. We do that every single time, so you can go back and see older presentations if you'd like, if you're interested. We'd like to hold questions to the end if possible. If you have specific pressing questions, feel free to put it in the chat function, which is at the bottom of your screen, and we can see if we can answer them, but we would prefer to hold all of those to the end. And with that, I'd like to move into presenting our wonderful guest tonight. Tonight we have with us Marin Gillis, PhD and LPH. She is the Senior Executive Dean for Faculty Affairs and Learning Innovation at Roseman's College of Medicine. Marin is a philosopher, bioethicist, and an award-winning medical educator. She is dedicated to advancing innovative applications of creative, conceptual, and critical thinking aimed at an empowered, resilient, inclusive learning environment and workforce and better health outcomes for patients, households, and communities. Dr. Gillis is an internationally recognized leader in education in the health professions and serves as director of the USA Working Group and director of International Academic Affairs for the Cambridge Consortium for Bioethics Education. She co-founded the Ethics and Humanities Educators in the Health Professions Affinity Group at the American Society of Bioethics and Humanities, where she served as co-chair from 2013 to 2020. And she's also a Harvard Macy Scholar. Dr. Gillis is the PI of a flourishing digital humanities lab called purplecoat.org, and she has published in the area of ethics and medical biotechnologies. More recently, she is devoted to the scholarship of medical and interprofessional health education. She served a 3-year term on the steering committee for the American Association of Medical Colleges Group on Women in Medicine and Science, and as Assistant Dean for Women in Medicine and Science at FIU, where she was also a division chief and the founding faculty advisor for the Gold Humanism Honors Society. She has held academic and administrative positions at the University of Nevada School of Medicine in Reno and the Massachusetts School of Pharmacy and Health Sciences University in Boston. Please join me in welcoming Dr. Gillis.
Thank you very much. Thanks for everybody for being here. I'm going to attempt to share screen. Okay, share. And now I want to put this into a presenter mode. Whoops. Okay, technical difficulty here. Got it. Hi, everybody. Thank you very much for that very warm introduction. Yes, this evening we're going to be talking about how to act ethically during a global pandemic. Some things we do will be the same as before the pandemic, and some things we do will be different. The last global pandemic was about a century ago, and there's really nothing to compare it to in our lifetimes. As one involved in bioethics, which includes the ethical consideration of policy and guideline making, my hope is for all listening to get a better idea of what things have been like for doctors, nurses, pharmacists, paramedics, and others who've devoted their efforts to cure and help alleviate the pain and suffering of others over the past 20 months. A colleague of mine who is a hospital-embedded clinical ethicist recently said to me, "If you've seen it, you can't unsee it, and if you haven't seen it, you can hardly imagine it." Thanks again to the Clark County Credit Union for sponsoring the series and for the Roseman scholarships they sponsor. Now, in addition to being a philosopher bioethicist, as you've learned a bit in my bio, I'm also an educator. And I will try to foster teaching and learning every time I open my mouth, which admittedly can be kind of annoying. And I promise that there's going to be no quiz at the end of this. But my hope is that you're going to take away some things. And so I've got some learning objectives. And they include, I want us to be able to distinguish what a moral intuition is from a moral assertion and moral reasoning. Also, the bulk of this talk is going to be to compare and contrast the ethical principles of clinical ethics and the ethical principles underlining public health ethics. I'd like us to understand concepts and values that underlie decision-making when we're talking about resource allocation and triage, and to identify the values that underlie some issues in the global pandemic management. Now, I don't know if any of you recognize this fellow. This is a character from a network TV show. Well, the TV show's over now, but you can see reruns. And it's the only show I know where one of the leading characters is a moral philosophy professor. And this character's name is Dr. Chidi Anagonye. The show is called The Good Place, and it's entertaining as well as pretty accurate when it comes to the philosophy. The show is premised around attempts to answer the question of what it means to be a good person and how to live a good life. And Dr. Anagonye uses methods of philosophy to get at these questions, and so will we tonight. Now, the first thing I'm going to talk to you about, and this is just, this is language, but it's just language, it's not special language, is the difference between an assertion, like any kind of assertion, and reasons for that assertion. And when we talk about ethics, like we can say, oh, there's ethics assertions. And that, for example, is a description. An ethics assertion is like when we have, for example, a Fox poll that says, who cares about mandating vaccines? And you get like, this many people do and this many people don't. When we have a picture of that, about how many people do and how many people don't on a survey like this, all we're getting is a claim, right? Like we're not getting any reasons for the assertion. We're getting a description of what it is that people believe, but that's not really where the action is. The action is really why they believe what they do. And for people like me, who's an ethicist, we try to get at, and to understand what the underlying values are behind those justifications. So I want to distinguish between mere assertion and when we talk about justification, that's a critical thinking approach or an analytical thinking approach, or basically what we do in philosophy, because you can articulate, you can have views, you can have intuitions, which is just a really quick form of cognition about what you think is right or wrong. So you can go vaccine mandates, mask mandates, or the opposites. And that's the first idea that comes up to you when you get presented with the question. But philosophical thinking about this is different. In philosophy, we articulate the reasons for why it is that we believe, or that we think that others believe, that something might be the case, like that something might be a good thing to do or a not so good thing to do. So we reflect on these to see if we have good reasons for believing them. And so what we like to do is just distinguish, for example, what I'm going to call conventional and philosophical ethics. And conventional are those mere assertions. They're those quick intuitions, that really quick cognition where you just have an immediate belief about something and you say, yes, I'm for this or against it. But in philosophical reasoning, we want to take a step further back to find out what the reasons are, and then to actually get into the debate. Once we get all the reasons down and we start to understand and do some conceptual clarification, do some logic to see whether I really should believe this for those particular reasons. And maybe what we do when we engage in these philosophical discussions together is that people might actually change their views and change their minds. So one of the things that I'd like to bring up, and this is a really great book called Thinking Fast and Thinking Slow. And philosophers like to deal with thinking. And when I talked about intuitions are just really, really quick cognitions. It's when a belief like bubbles up to the surface immediately. And that's fast thinking. And the good thing about fast thinking is, well, it's like fast, right? And it can give you some kind of sign. It can give you some kind of guidepost about what you might think is the case. And slow thinking is used for really important problems. And we only use slow thinking when something really, really matters to us. And it takes a lot longer to do the slow thinking, but it's reliable. Right? So when we're doing ethics, even as a philosopher, we're doing fast thinking and slow thinking, but the philosophers tend to be with the slow thinking. And that's another reason why philosophers are considered to be kind of annoying, is that we really like to talk about everything for a very long time. Now, we're going to do a little bit of ethics theory here when we start to talk about values and beliefs about what is good and what is bad. Now, sometimes when we talk about ethics of certain kinds of things, like I gave you the example of mask mandates, or we could talk about anything in the area of bioethics, like from physician-assisted death to abortion to destructive embryonic stem cell research, whatever it's going to be. When you're talking in a clinical setting, though, when we're talking about whether an action is right or wrong, there's different ways to go about it. And sometimes we think, if you start to unpack this, that sometimes you think that there are actions that are just inherently wrong. Okay, so you don't do them because the actions are just so wrong, or you do them because that's just the thing to do. That's a good thing to do in itself. And sometimes you don't do it because it's not even so bad. Some people think that some actions are so bad that the word bad isn't even bad enough. You have to call them evil, right? So there's actions, and you say, the action in itself is something that one should not do. The action is inherently right or inherently wrong. And when you start to unpack that kind of way of talking about right and wrong, you have to have, well, how is it that we can find out what these actions are right or wrong? And there's different theories that come up with them. So one theory, for example, is in a lot of religious-based ethical theories, and it's called divine command. So the actions that are right or wrong to do are the ones that your divine Godhead tells you are right or wrong. So things like the 10 commandments can come into our mind for what you do that. So the right thing to do is to follow the commandments, and the wrong thing to do is not. And that's in a divine command theory. There's another theory, and it's called deontology. And in deontology, the whole thing to figure out whether or not, whether or not an action is something that's right or wrong, is whether or not we have a duty to do it or a duty to avoid it. So in that ethical theory, the whole meat of it and what you're trying to find out is, what the heck is my duty, right? You know, what is it that I'm being commanded to do? What should I do? What is my duty? Now, the other way to look at actions, right, to see if they're right or wrong or good and bad, is not to look at them as inherently or intrinsically right or wrong, is that an action is determined to be right or wrong depending on what consequences it brings. Okay, and anybody who's involved in healthcare really can resonate with this, because for a health intervention to be considered good, it's going to be good if it brings about good outcomes, and then health intervention will be bad if it brings about bad outcomes. So there's nothing inherent in the action itself that's right or wrong or good and bad. You're looking at the rightness or the wrongness, like whether you should do this or should not do this depends on the consequences that follow from what you're going to be doing. And a big theory, like these are all called consequentialist theories, but a theory that you may have heard of, like if anybody's ever heard of cost-benefit analysis in economics, it's based on consequentialist ethics theory. Okay, so you take your stakeholders and you find out who could benefit and who could be harmed by a particular policy that you're considering. And then you say, the policy is good if more people are benefited from it than harmed by it. Right? So an action is good if it brings about the greatest consequences for people and it avoids the most harm for people. So that would be considered a right or a wrong action from that perspective. And so when you're talking about actions, then words that are really important are things like agency, and whether or not you have the capacity to be able to make the decision to do actions. So these are very familiar to us because of, this is embedded in the law, right? An action has to be voluntary for somebody to be responsible for it, right? And you have to be thoughtful. You have to be able to think through something in order to be responsible for it. You have to analyze the intention of the person who's doing the action. And then you have to look at the consequences of the action. Now, that's one way of talking about ethics, right? Is to look at the actions and say, okay, we'll do something if it's a good thing to do. We'll avoid it if it's inherently bad. And then other folks will say, okay, no, we'll do the good. We'll do this thing if it brings about good consequences, and we won't do this thing if it brings about bad consequences to people. But there's another way into ethics, and this is something that resonates with us, and all of us can look at this. And anybody who's involved with the healthcare field and has taught professionalism, this will resonate with you. And this is a different kind of ethical theory. And what you start with is to say, what does it mean to be a good person? Like, what are the character traits that are associated with being a good person? And in healthcare, how this translates is in professionalism is we say, what are the traits of being a good nurse? What are the traits of being a good pharmacist? What are the traits of being a good physician? And we try to develop those, and how those traits are developed, right? Like, we want you to be developed in order to be like a good physician, let's say, and it becomes part of your way of being as a physician. In another way, like we just say, like not in a healthcare field, just in a general way, talking about human beings, you'd say what we're trying to do is to develop your character. And character means that you have certain kinds of habits of action. So, for example, and there's usual, for, let's say, patience is usually considered a virtue or a good character trait to have. One of the things we'd say is that, you can't be called a patient person unless you do patient things. Right? And so how do you learn to be a patient person? Well, you get role modeled by people around you that practice it. And then after a while, you'll find out the point of it. It's just like being a good doctor or a good nurse or a good pharmacist or a good dentist. Like, we put you in situations where you have role models and you do what they do so that you start to kind of fake it till you make it. And then after a while, we'll teach you the point of why you do things the way you do. So there you've just been given a 3-minute, 5-minute ethical theory primer. But the point of it is, when we're talking about right or wrong or good or bad, we're talking about two different playing fields. We're talking about an ethics of doing, right? We're talking about the actions in themselves, if they're right or wrong, or whether the consequences of the actions are right or wrong. And we're talking about the ethics of being, which means, what does it mean to be a good person? Now, the last tool that we're going to have in our philosophical kit going forward is logic. And this is another whole area. But the two things that I want to leave you with when we're talking about the laws of logic is first the law of non-contradiction. And when I tease my students, I say, we have to be on the same playing field when we have these conversations, and we have to abide by the law of non-contradiction. And they say, what do you mean? That's just your logic. And I kind of think that that's the same thing as my parents for something, when I was growing up, and you'd say something about what one of my parents would say, and my father would say, like, what's logical is what I think is right. And that's really not what the case is, right? I mean, non-contradiction means something and its opposite can't be true at the same time. Right? So I say to my students, well, what I mean by that is, if I were going to tell you there's a test on Tuesday and there's not a test on Tuesday, and both of those things are true, I would literally make no sense. So in order for us to be able to speak to each other and make sense, we all have to agree to abide by the law of non-contradiction, because once we've self-contradicted, nothing makes sense anymore. We have to start afresh. The other thing that I'd like to leave you with is something called the Naturalist Fallacy. And that's just a claim that just because something is the case, like it's a fact, it doesn't follow that it ought to be the case. And so go back to that Fox poll I told you about. Just because the majority of people believe that it's true doesn't follow that it is true, because we could be wrong. Right? So that's why we need to have reasons in our conversation when we talk about these kinds of things, because otherwise all we have are assertions, and the naturalistic fallacy, it obtains in those situations, because just because something is the case, it does not necessarily follow that it ought to be the case. And here's something you can take a picture of. And I'm loving that I'm speaking to you to everybody right before Thanksgiving, because you know Thanksgiving is famous sometimes for having really heated discussions amongst family members. And if you take a photograph of this, like I invite you and I invite you to invite the people at your table to go do a philosophical health check. And what this is just a series of quick questions. There's no right or wrong here. We're not talking about right or wrong. We're talking about logical consistency. And so after you take this little quiz, it gives you information back about, not about the rightness or wrongness of your beliefs, just simply about the consistency of the beliefs that you hold and whether or not there's any logical tension amongst them. And as I said, if you think that having political debates at the dinner table might be a source of entertainment, being able to talk to people about why they don't even hold their views consistently is just even more fun. So with all that being said, I'm going to take a little breather here. And we're going to move to healthcare, and we're going to see where all this rubber is going to meet the road. Now, there's lots of different sources of ethical guides to health professions, like, to clinical care. And some of you may have heard of the 4-principled approach. I use a version of the 3-principled approach. And what this is, and I put it here to just show you how the ethics of doing and the ethics of being come full circle into these kinds of discussions. Now, the principles of doing are, and these are, considered to be very, the lenses with which a healthcare professional should be looking at medical decision-making and treatment of patients. And the first is the primacy of patient welfare. The second is respect for patient autonomy, respect for persons. And the third is the promotion of social justice. And then there are commitments, and this kind of goes together with the virtues of what it means to be a good healthcare professional, like what kind of commitments that you have to have, what kind of, how you are positioned in the world, how your being is in the world as you take on the roles of a healthcare professional. Now, I'm only going to be talking about the principles, and I'm going to unpack them. Now, unpacking the principle of primacy of patient welfare means first, do no harm, right? That should sound familiar to a lot of folks. So that's called non-maleficence. Like mal is a Latin word for bad, right? So and we were speaking earlier of Maleficent, that Disney princess, she was a baddie too, right? So mal means bad. So do no harm. Beneficence is also wrapped up with that. And bene is good. That's Latin for good. So when we talk about the primacy, beneficence is being part of that, what beneficence refers to is the goals of healthcare, which are to cure, to relieve and prevent suffering and disease, and to rehabilitate. It also involves, to do good for the patient means to follow evidence-based medicine and standards of care. And finally, the principle of patient welfare involves the best interests of the patient. It's paying it, how you should act is in the patient's best interest. And what this means is simply not in your own personal interest, or not in the person, like a doctor, or not in the insurance company's interest, or not in the hospitals or whomever's business, interest of the patient first. And that should help you what my guidelines for the best interest? Do no harm, help. Okay, primacy of patient welfare. But there is an assumption here, and the assumption here is that life is better than death and that less suffering is better than more suffering. The next is a principle to unpack is the principle of autonomy, respect for persons. And operationalize, this is where voluntary informed choice comes in, right? So we have informed consent and we have informed refusal. So what this means is that we have to respect a patient's decision-making, that if they are given all the information, right? So what is the procedure? Okay, what are the risks and benefits of this procedure? What are the risks and benefits of this treatment? What are the risks and benefits of the alternatives, if anything? What are the consequences of doing nothing? And then we'd say, and that has to be done in a way that a patient can understand, right? So once they make a decision, yay or nay, in the informed consent process, this is how it is that the principle of respect for persons and the respect for patient autonomy comes into being. It's in the medical decision-making process. Okay, so this is how respect for the dignity of human beings is operationalized. And it's by being able to give the patient all the information. And there's a little slogan that usually comes up with this. It's nothing about me without me. Now, the next the principle, or sorry, the unpacking is the principle of the promotion of social justice. And social justice means a lot of different things. Like first, it means distributive justice. And so this is scarce resource management, right? Because there's always there's always more people who need resources in healthcare than there are resources available. So first in distributive justice, you've got the question of like, for example, who gets the chemo, who gets the kidney, who gets the IVF, or who gets anything at all. Then under distributive justice, which is going to be, I'm waving a flag here, I'm doing the foreshadowing, is disaster and triage ethics, and also the duty not to waste. Also in social justice is the ideas of equality and equity. And what this refers to is fairness in treatment and research of any population or group, a concern for vulnerable populations and health disparities, and the social determinants of health. Now, when people like me come in, or when you're doing clinical ethics consultations, or what I'm teaching in the class, and we're talking about ethics issues, how and why I bring up all this background is because the way we can talk about difference of opinions and ethics in the clinic, or in anywhere, but in the clinic in particular, because this is, the principles that I'm referring to, is that I talk about things in terms of dilemmas, right? So it's when you have a problem is when the values rub up against each other, where you can't have both at the same time. If you have one, you're necessarily going against the other. So I'd say, what is an example of something that promotes patient welfare, but the patient doesn't want it, right? And since we're talking about COVID, I bet a number of you are saying vaccines, right? Like here is an offer that somebody can be protected against something, and it's in their own welfare. It's to help them, not to hurt them, but they don't want it. Another classic example of this, like pre-COVID that we talk about, is an adult member of the Jehovah's Witness faith who, when let's say there's a consideration of them having a life-saving blood transfusion, which would be the best, practice for, let's say, a particular accident, but the patient doesn't want it, that's a conflict between the primacy of patient welfare and respect for patient autonomy. Because if I gave this person the blood-saving transfusion, I wouldn't be respecting their autonomy. But if I respect their autonomy, I'm going to not be acting for the primacy of patient welfare. Another example is something that does not promote patient welfare, but the family or the patient want it anyway. And a really good example of this one is when, for example, a patient wants an antibiotic for a viral infection. Right, they're demanding it, but it's not in their medical interest to have it. It's not going to help them at all, but they may want it. And the last I'm giving you as a dilemma is an example of something that promotes social justice, but the individual doesn't want it. And here again, this is a lot of public health, right? Like, so it would be something, for example, I was talking with a colleague recently, and we're talking about like Gardasil, right? Like Gardasil is given to boys, and yes, it does prevent some kinds of throat cancer, but the reason why you would want to give it to the boys is because in the future, the women that they might be, having sexual relations with, it's going to protect them against the HPV virus, which causes cancer, right? So it's not about your own self, it's about somebody else. It's about something that you can do, but that it has effects on other people. Now, pre-pandemic, okay, the only reasons for there to not be a proviso of treatment would be because the patient refused it, and if we're respecting patient autonomy, the patient has a right of refusal if they have the capacity to make medical decisions for themselves. If the treatment is not beneficial, because that goes against the primacy of patient welfare, right? It might not be evidence-based. Somebody might be asking for a cure that has absolutely no evidence to it whatsoever, and it actually might be harmful. or the conscientious objection of the provider. And that could be an entire talk in itself, right? But for now, there are certain kinds of health interventions which are legal that physicians and nurses, for example, like primary care delivery folks, are protected if they conscientiously refuse to want to provide that service for somebody for whom it is necessary and who wants it. But those are the only, reasons why healthcare would be denied. Now, here we have a painting, and it's done by Edvard Munch, and it was done in 1919. And people might know Edvard Munch for his very famous painting called The Scream. He's a Norwegian artist. And he did this self-portrait while he was suffering from the effects of influenza in 1919. And so here we are again, you know, for 20 months, we've been experiencing a global pandemic. And the last one was 100 years ago. Now, when we start to talk about ethics and pandemics in healthcare, the approach now is more of a public health or a social justice approach, whereas in the clinic, we're really concentrating on medical decision-making between the individual and the provider, right? We're doing some decision-making based on the primacy of patient welfare and based on whether or not the patient wants to go forward with the treatment or not forward with the treatment. So we're talking about respect for patient autonomy. And when we did talk about social justice, usually in the clinic, it usually was only about non-discrimination. You know, that was the only time that social justice usually appeared in the clinic. But with the pandemic, it's like we reversed the three, right? Like, so that all of a sudden the promotion of social justice is front and center and individual decision-making is not, right? So we're highlighting that. And why we're highlighting it is because of one reason, and it is scarce resources. It's how do we fairly allocate resources in a global pandemic. So there's a tension, right? Like there's, instead of prioritizing primacy of patient welfare and respect for patient autonomy in persons, we're prioritizing the promotion of social welfare. And because there's a crisis, an irregular situation, we're going to have the problem is resource shortage. So whereas before COVID, in the clinic, in the hospitals with their treatments, we were looking at our duties to focus on an individual patient, but in times of crisis like that, we have a focus on the community. Now the R word, right? This is a really difficult word to talk about, rationing. But rationing happens. Rationing, there's even in the best of situations, we don't, like I said before, we don't have everything that we need for all people. And sometimes we don't even think about this, but the healthcare provider, it's her or his time as well that is a scarce medical resource. So our only decisions are explicit rationing or implicit rationing. And I think we have a duty to explicit rationing. Again, the philosopher in me, we have to have reasons for our rationing and they have to be transparent. So in a crisis, we should seek to limit the implicit rationing in favor of the explicit rationing. Decisions have to be made, right? Decisions have to be made and they should be made in a systemic way. And there needs to be guidelines. Now, one word that you might have heard of before in these kinds of situations is the word triage. And so in times of crisis, and this word is a French word that was, it's a French word from agriculture I recently learned, and it was appropriated during the Napoleonic Wars to refer to sorting out injured warriors so that they could make a decision about who was going to be treated first. And triage was also used in the US Civil War. We had triage in the First World War and the Second World War and the Korean War. And it's a systematic allocation of medical care when the patient's needs exceed the available resources. So we say, when we have a need situation like this, we have to be systematic about it. We want to be explicit with our rationing guidelines. So we're going to go to triage. And I'm dating myself a bit here, but the first time I learned of triage was from the television show MASH, like, you know, the mobile area surgical hospitals. And I remember as a very small child watching this, when you're looking, when the helicopters would come in, and I remember the first thing that would happen, all these injured folks came on and they'd get numbers. They were being sorted. And what they were being sorted for was who's going to get care first, and if second, third, and fourth. Right? So this is your standard triage where you've got the minor who, you know, if they don't get care right away, they're probably going to be okay. There's delayed that, you know, they need care, but it can wait. It's immediate where they really need it right away, but there's like a really good chance that they're going to be okay, but they need the immediate intervention. And then there's those who are determined to, like, they really need it as well, but they're probably not going to make it even with the help. And the people who are prioritized are the immediate ones, right? Those are first. And the last are number 4 on this list. So what happened is in the 50s and the 60s, like, so the Korean War was in the 50s. In the 60s, it's been happening. Like in medicine, all of a sudden, we have technological advances in medicine that are extraordinary, right? Like this is when all of a sudden you have, like, we call it like the magic bullet, like magic bullet and drugs. Like that was, you know, in the late 40s when antibiotics came on. But we have the start of amazing technological interventions and pharmaceutical interventions so that we can do things like do organ transplants, right? The early days of hemodialysis, where all of a sudden people who were in kidney failure had a second chance at life. And of course, emergency departments started to be on the scene with all of their technologies as well. And so triage, the concept of triage now goes over into civilian medicine. Because people were saying, oh my goodness, we've got these amazing machines, we've got these amazing technologies, and we have all these people who need it. How on earth can we make decisions about this? And the photograph that I have here is from a Life magazine article from the early 60s. And this is a photograph of some of the members, some of the actual members. And this was the photograph that is from the magazine. At the University of Washington in Seattle's hospital, where the dialysis machines had started to be used. They were invented at that university, and they were starting to be used. And they put together a committee, and this is considered the first ethics committee at a hospital, to determine who was going to live and who was going to die. In other words, who was going to get the allocation of the dialysis machine and who wasn't. And so the good news is that they were actually thinking, you know, this is not just a medical decision. This is not just a scientific decision. This is a decision that the community folks, that folks from all different walks of life have to talk about. What is it about our values that we want enshrined in this? Because we have to make a decision. It has to be transparent, but we want it to be the best possible decision. So they were very earnest. So the good news is that they had a committee and that they wanted it to be representative. The news that's a bit less palatable for us now is that of the criteria they came up with was something called social worth. So they literally decided that, for example, people who were married had more social worth than people who weren't married, so that they should get priority for the resource allocation to live before anybody else who wasn't married, because they were considered to be more valuable to society as a married person. And they also had a criterion about, you know, how often one went to church, and that was considered to be a good indication of one's social worth. And of course, it was a Christian church, right? So, you know, the kind of criteria they came up with are very questionable, but that they decided that they tried to come up with a community standard, and that they were doing it without just medical folks, that they were doing it with folks from all different life parts, you know, areas of life, was a good thing. Later on, then what happens is that JCO at the time, it's now called the Joint Commission, said, you know, we've got to start to not just use triage, right? Like we need to something more robust. And we really have to think about this, and these guidelines have to be broad, and we can't include things like social worth category because that just doesn't make any sense and it doesn't seem really ethical. So we have to have planning documents for how do we allocate scarce health resources during public health crises. So they developed something called crisis standards of care and refer to crisis standards of care as opposed to like regular standards of care or conventional standards of care. And the Institute of Medicine, which is now called the National Academies of Medicine, because of Katrina and because of the H1N1 pandemic, develop these standards, okay? So what we have now, like we had a duty to care and we have a duty to allocate fairly, is a duty to plan. So systems for frameworks for catastrophic disaster responses, the legal ethical guidelines, what to do when there's too many patients and not enough resources, what kinds of decisions, how can we make decisions? And also what the crisis standard of care did was protect healthcare workers from liability from deviations of conventional standards of care, which is really important. So in 2009, I'm just getting my little thing here, it started in the States. And when COVID broke, folks, 17 states had them. So a crisis standard is defined as a substantial change in the usual healthcare operations and level of care it is possible to deliver, which is made necessary by a pervasive, example, pandemic, or catastrophic, example, earthquake or hurricane. This change in the level of care delivered is justified by specific circumstance and is formally declared by a state government in recognition that crisis operations will be in effect for a sustained period. The formal declaration that a crisis standard of care enables specific legal and regulatory powers and protections for healthcare providers in the necessary tasks of allocating and using scarce medical resources and implementing alternative care facility operations. So in 2020, as I said, like 36 states were actively developing it, but only 17 had it. And 11 of the 17 plans had to be updated, and a majority of them addressed ventilator usage, influenza planning, pediatric care, but fewer of other things. And the 5 states that were the best in this, are you ready for it? Arizona, Colorado, Minnesota, Nevada, and Vermont. According to experts in this field, Colorado and Minnesota have all hazard documents and processes for both adult and pediatric populations, and so should be considered exemplars. But look, obviously there's a problem. Many states lacked any available guidance on maintaining standards of care during disasters, and many states with specific care guidelines had not sufficiently thought them out. So when we're talking, remember before with our duty to care, and it was really focused on the individual decision-making. Now with scarce resource issues and guidance for policies, we have to balance the duty to care and the duty to fairness, which is equality and equity. And we also have a duty to communicate it. So when we talk about this, what do we want when we're talking about allocation of scarce resources in a big scale? The 2 most important considerations are that we want to do the best with what we've got, and we want it to be fair, right? We want to do the best of what we got. We want to have the best possible outcomes with what we've got, and we want it to be fair, because everybody's equal with regard to their being a human being, right? Everybody should be regarded equal with regard to, having dignity. So if we want to respect everybody as equal, we're going to say, how is it that we can be fair about this distribution, but utility, like getting the best done with what we've got, is what we're also valuing. So we're putting those 2 together, and we're going to try to come up with some ways of dealing with this, right? Because the problem is, like, how do you operationalize utility? Do you mean the most lives saved? Do you mean the number of years saved? Do you mean the best quality of the years saved? And when you're talking about equality, like, what do you mean to treat people equally? Is it like first come, first serve? Like, is lottery the best way to do this? Or should we pay, special attention to those people who've experienced like tons and tons of injustice already? Like, how do we do this, right? So people talk about this, and the first thing that you have to do is to identify exactly what you need in the scarcity of the resource, right? Then what you try to do is maximize the supply and minimize the demand. And a lot of people, I think at the beginning of the pandemic, heard about like flattening the curve. This is what flattening the curve is all about: maximizing supply and minimizing demand, right? And why do you want that? It's so you don't have to engage in scarce resource. You're trying to preserve the resources that you can. You want efficacy. You want it to work, right? We will endeavor to so we want it to work, which means whatever we have to offer, we want it to make sure that it's actually going to do something, right? And we want to maximize good outcomes. And we want to apply the guidelines equally and be mindful to be consistent of it, right? Like you can't just use one guideline one week and one guideline the next, or one guideline with a certain group of people and one without, right? So here's when we talk about explicit values, what the usual suspects are, right? Like when people start to develop those things. So you say, okay, like, and this is, you're reminding of triage, right? Like prioritize those who most likely survive the current illness. Then this one's a bit more debatable, right? Like prioritize those who are likely to live the longest after recovery, right? And there's a red flag there, right? There's already a red flag there because you're thinking, some folks already have comorbidities. Some people also have certain kinds of disabilities. Like, are you kind of discriminating against older folks? Prioritize those who've lived fewer life stages. Again, you have to be careful about that, right? So it's to say, when push comes to shove, if we're all equal here, then like if we're talking about fairness, like maybe it's fair for those folks who've had going through different life cycles, they've already done it, and those younger folks haven't yet. So maybe they should be prioritized so that they get the opportunity to go through more life cycles. There's another idea, and it's to prioritize those who have social utility. And people might have heard about this, right? This was being talked about a lot, in that we should prioritize those folks who, for example, if they get sick, if we give them the resource and they get back on their feet quickly, they can go help other folks, right? So those would be your healthcare professionals, right? So we're saying, well, maybe those folks should get it first. But I think you recall, and everybody knew this, right? Like my Amazon driver kept me through that pandemic, right? My Uber drivers who brought me food, right? The folks who drive trucks, getting that toilet paper from state to state was really, really important, right? So what we consider essential workers, we really had to think about during this pandemic, right? So should you prioritize the worst off? Should it be first come, first serve? Should it be a lottery? I mean, my goodness, like these were the questions that everybody was grappling with. And did I say that I think that we have a duty to plan, that it's usually better to do this like before a global pandemic happens? 17 states were ready. So healthcare rationing steps already happened right at the beginning. And everybody remembers this, right? That hospitals were postponing elective surgeries. Physicians and nurses immediately went to telemedicine, right? And lots of other folks too, like, lots of other health professionals went to telemedicine. Some physicians, online visits rather than patients in person. But more serious steps had to do with deciding who was going to be treated, for example, in a regular care unit or an ICU unit, and who could be cared for in a lobby or a classroom. Right. So now, I mean, this was from an article that I read that was just in September of this year, and it's a tale of two states. And these two states are Western states, and they both Idaho and Montana, and both of them were going through the considerations that we were talking about right now. Both of them were had that they were looking for interventions and scoring folks on those who would do best with the intervention. They went for the life years. They thought that was important, so they decided that would be fair. If you had underlying conditions, you were going to be a riskier candidate for this. Because on these things, the higher your score, the worse it is, because that means you're sicker or you're less likely to recover with the intervention. So the lower the patient score, the most likely they were going to be to help this. And so, they also had tiebreakers. What do we do? If there's people who basically have the same score, what are we going to do? if there weren't enough resources for all folks at the front line. Youth, the age was the biggest tiebreaker in both of the guidelines with these states, with the younger ones getting the top priority. In Idaho, pregnant women who were at least 28 weeks along with viable pregnancies came next. Both states also gave consideration to younger adults ahead of older adults. And Idaho's fourth tiebreaker was if the patient performed a task that was vital to the public health crisis response. And then the final tiebreaker was going to be a lottery. Okay, like after all said and done, if it was still the same, there were going to be a lottery. So what ended up happening is that after all these considerations, and they were very similar, this is a policy that each of the states came up with. In Idaho, for their crisis standards of care, they came up with a universal non-resuscitation order, which meant like all at once, every adult in the state had a DNR. And what that means if you have a DNR is if you have a sudden heart, if you have a cardiac arrest, like a sudden cardiac arrest, that means no chest compressions, no attempts to shock the heart back into normal rhythm, no mechanical organ support. And also the reason why they did this is because it's not just the machines. To do resuscitation requires a lot of staff, right? So you'd be pulling staff away from doing other things. In Montana, they had similar deliberations, they had similar ideas. And what they came up with was that it was a matter of individual doctors, case to case, do DNR. Very different outcomes. So, but in both of them, and I mean, I won't, like, these are, I'm not going to go through all these things. These are, we've talked about all these things, but it's about, what are the vision and values for crisis standards that people have been talking about across the board? These are the things that people are trying to wrestle with. They're trying to get on paper policies and guidelines that capture these values, right? So that they're fair, that they're equitable, that people know them, that they're applied consistency, that they're proportional to the crisis at hand, right? Like, what do you really need to address this crisis? People are accountable. There's community and provider engagement, education, and communication. They're legal. That the people who are implementing the guidelines have the authority to enforce them, and that people are in it together, right? Like that the environment is such that all of us understand that we have to do this, and we know what's happening. Right? Because I don't know how many people on this call even knew there was something called a standard crisis, the crisis standards of care, and that the state had a plan for this, right? And that right now in Idaho, it's in effect. So here's something that with different guidelines that are coming out. And the reason why I think this one's important, and this is something that a lot of people have been following, because this is a very specific one about ventilators, is that it was to separate the committee who was making the decision about who was going to get the resources from the clinicians at bedside, right? Like it was separating the decisions for scarce allocation or resource allocation, i.e. the triage decisions. It had the committee making the triage decisions, and those folks were different than the folks on the front line who were delivering the care to the patients. Like, do you see that line, right? So the triage committee was making decisions, though, based on charts, right? They didn't have any interaction with the patients. Now, this is a decision-making flow chart that's for making medical decisions for people who lack capacity, right? And this is just your basic flow. This is just healthcare decision-making 101. And it is, again, when we're trying to do what? Like the green line around each of these things means that we are respecting patient autonomy, respecting persons. And if it's got a blue, it has to do with promotion of patient welfare. So basically what this is to say, we want a medical decision to represent what the patient's preferences and values are. But if we have no way of telling what a patient's preferences and values are, then the physician decides on the best interest of the patient, which, as we know, is grounded in the value of the primacy of patient welfare, right? So the Montana model is basically mirroring what we already do, and it's starting, at that lower corner. And so when we start to think, we don't have to go so much to the extreme, right? Like we can still represent the patient's preferences and values when we are going to talk about being admitted to the ICU. So let's try to get some guidelines to get the patient's preferences and values back into this. So let's try to find out, even if it's only through the charts, what the patient's preferences and values are going to be. So this is a lot different than just having a score based on their clinical, based on clinical notes and lab values about whether or not a patient's going to survive an intervention, right? At least the patient is present and we are having an opportunity to respect autonomy. Now, here's a chart that everybody's been using, and it's from the Hastings Center. It's talking about when you're doing your like having a guidance for policy, you have to think of resources in three ways. You have to think about stuff, you have to think about space, and you have to think about staff. On the one side, you've got the usual operating conditions. On the other hand, you have catastrophic failure, right? And this means like when we're talking about space, all beds per usual, elective discharge, all in place reserve beds too. Some areas are unsafe to move patients in. And if anybody remembers the Katrina stories about what happened at Memorial Hospital in New Orleans during that time, when you had people who were just in hospitals that were in just horrible conditions, and that they were trying to make the best of what they could. It was a crisis situation. Or when you hear now about adults being cared for in pediatric ICUs, like this is what we're talking about with the standards. It's to say, let's look it out. What can we do? What are we going to call this? Now, notice that all of us are talking about like with the crisis standards of care or versus the conventional, but there's something in the middle, okay? And it's the contingency. It's when not all things are scarce at the same time, right? When we're not totally catastrophic all the way, right? We're kind of in the middle there. And here's one of the issues is that throughout COVID, it never happened that everything went all at the same time everywhere, right? Like some jurisdictions, some hospital systems, things were getting really dicey, and it's not over yet, people, right? It's really not over yet. But nothing ever happened. And so I remember at the beginning of the first things I was asked to talk about with ethics was the protective, the PPE, that there was no reserves in the hospital for PPE. And so doctors and nurses and everybody who worked at the hospital were being asked to bring their own in and to treat patients with COVID, right? And there was no vaccine at this time, right? And to treat people without PPE. And this is something, so you don't need a state order to declare an emergency for PPE, or maybe you do, I don't know. But the thing is that it was just a certain aspect of a shortage. It wasn't all the way down, right? So it was in the middle. So we never considered in all those policy makings that there might be a sustained shortage of certain kinds of things, but not everything, right? Everybody was spending their time at the beginning talking about ventilators. Next is consistency, right? Like, when I showed you the tale of two states, the tale of Idaho versus Montana, and how different their policies were. I mean, that's like, we need more consistency. And that there were only 17 states ready in 2020 also shows that we need some consistency. And when we develop these policies, everybody needs to be at the table. We have to be able to represent constituencies as much as we can, because there was an issue with equity, right? There was an issue with equity. COVID-19 laid bare the structural inequities of our current healthcare system, and it made the aspirational goals that we had with the crisis standards of care almost completely unachievable. And it highlighted that some groups might even be unfairly penalized, right? And so I'm talking about people who, like, for example, relied on public transportation to getting their health care. I'm talking about people in skilled nursing facilities, people in detention facilities, and also in essential workplaces. So all this stuff was magnified during the COVID crisis. So when we're talking about trying to address that and allocation to resources, we're having to do things and to strategize through things like having vaccine clinics in churches and serving people where they're at. And that's something that we're doing at Roseman with our vaccine clinics, is that we're not telling people to get out to Roseman. Like, we had vaccines, but Henderson was far away, Summerlin's far away. Like, we've got to go to where the people need it. And so this idea of pop-up clinics is a way to start to address that kind of inequity. But we have to make sure that the protocols that used for making urgent allocation decisions cannot be expected to remedy historic or structural racism, but they shouldn't exacerbate the underlying disparities, right? So that's what we should be cautious about. So what else has changed in hospitals with the crisis standards? And the answer is just about everything, right? Like just about everything has changed going to the hospitals. Like we wait longer. We wait longer in hospitals. We wait longer in urgent care. Lots of people who were going through cancer treatments were very affected by this. Some people were just sent home, as early as possible, and had to rely on people taking care of them at home. Some folks, were just on stretchers in anywhere we could get them. I think a lot of folks remember, like in certain places, like in the Hackensack Meridian system, and that's just outside of New York City at the beginning, where you'd have all those clinics outside in the parking lots, because there was not enough space to triage all the people coming in. But the last issue that I want to talk about with any kind of depth is this idea that's coming up. And if you start to do a Google search on the word moral distress, you're going to just see it popping up like hotcakes all over the place with regard to COVID-19. And this is some words that I took from an editorial of a nurse. And she just said, like moral distress was brought up in the 80s. And it was referring to nursing, but it does have its attributes everywhere else. And moral distress is when a practitioner believes that they know what the right thing to do is, and that there's systems and power and authority that doesn't let it do it, right? And one of the biggest things that caused moral distress during the pandemic for the frontline healthcare workers was in the ICUs or in the hospice units, where people were dying alone and nobody was able to be there with them. And there was so much death and there was so much dying alone. Like you saw pictures of like healthcare providers, with their own cell phones trying to get linked up with folks so that people could say goodbye to their loved ones over the phone, and this has really taken a toll. The lack of PPE has taken a toll. The fact that nurses have to go and take care of many more patients than they had to before, and that their hours are longer. And they too have families who need help, right? And this one woman said, like, how much dying can I take in an hour and not be affected by this? And again, also what they have reported was that there was a real problem with this healthcare hero language, right? The heroes of healthcare, when they were basically saying it was just like, trying to put up your hands against a tsunami. They didn't feel very heroic at all. And in fact, it just made them feel worse. Now, of course, there's all sorts of other issues. Just by the way, I wanted to say with that, there was it was just an article that was published a few days ago in The Atlantic. And I really have to point this out, folks. The crisis among healthcare workers cannot be overstated during this pandemic. And the article reported that 1 out of 5 workers, healthcare workers, and these are mostly highly trained nurses, have left the field since the pandemic has started. Can I say that again? 1 out of 5 healthcare workers has left the field since the pandemic has begun. And one of the quotes that I have from a nurse was like, she said, look, I love my job. I love my calling. She said, but my exhaustion and my rage is for real. It's there. And she said, and now the largely unavoidable ongoing nightmare of the pandemic cannot continue indefinitely. Like that original colleague I told you about, who's a clinical ethics, said, there's nothing to compare it to in our lifetimes. If you've seen it, you can't unsee it. And if you haven't seen it, you can't even imagine it. So look, we've got other public health issues that I'm not going to get into them, but they're all the same in the sense of what are the values underlying this. And you have a problem with respecting what an individual wants, for example, with what is the need of the group, what's in the best interest of the community. So you're having these conflicts between individuals and communities, right? You're having conflicts between what an individual wants to do, with their own bodies, and you have what is demanded to keep the community safe. So yes, we do have legal and ethical responsibilities. I mean, the Constitution is there to protect us, right? Fundamentally protect the people. Governments have a duty to protect the public. And so there is legitimate legal authority that they may opt to maybe do things that some folks think are aggressive measures to curb the spread of the pandemic disease. And this can challenge thinking about the scope of the state's interference. And yes, we need medical and public health sciences information to inform our decision-making. But what I've been trying to point out to you is that there's values everywhere, and we have to think about them, we have to talk about them, and we have to be consistent with them, and we have to make them transparent. And we need as much consultation with groups and human experiences that we can possibly get. Because science alone is insufficient when we're forced to consider and prioritize competing ethical values, because this is what these debates are about. Scarce allocation of resources is an ethical debate. And again, conflict of values, utility versus equality, utility versus autonomy, professional duties versus my personal concerns, and the community versus the individual. So my friends, that's all I've got. So thank you very much for your attention. I am open to answering the best way I can any questions. And I know that there's lots of experts already on the call that can help out too.
Are you open for questions now?
Sure thing.
I have a question. First of all, congratulations for an excellent presentation. Okay, it was very, very well done. But there is an issue that has been created in the current pandemic. How do you deal with the issues that are ethical and scientific when some of these options have been highly politicized? The mandates, you're absolutely correct. The government has a responsibility to assure the population the best outcome. But one of the problems with this COVID-19 is its ability to transmit very quickly, and enhanced by the new options that the virus is presenting. But some of the mandates are designed to minimize the transmission. But for political reasons, people are choosing not to use them. Has the government have from an ethical point of view, the obligation or the option at least to issue mandates?
Well, I think, yes, they do. But I think to your point, you're absolutely right. One of the biggest problems that we have is that it's become politicized. And I've thought about this a lot. Like, I talk to people in the dog park, right? You're talking to your neighbors, and somebody said, I have a right not to wear a mask. I have a right. And I'm a philosopher, right? I'm annoying. I just said, what kind of right? Like, it's not a legal right. You have no legal right to do this. I said, well, and they said, well, it's a God-given right. And I said, well, okay, then that's that's a moral right. And I said, you have no moral right to do this, right? And I can argue that. What I really think, and people have started to write about it. There's a fellow, he's a bioethicist named Timothy Caulfield, and it's C-A-U-L Field. And he thinks, and I think he's probably, I think there's something to this. He says, okay, yes, it's politicized. Let's get that. There's no moral argument for a lot of this behavior, right? Because the government does have the right, there's mandates. It's completely moral to say that if it's not going to be of any harm to me and it's going to benefit other people, I have an obligation to do it. He believes that it's because of not believing in the science. He believes that most of the people are using ethical language, but it's not ethics. And we've told them it's not an ethics issue. They really don't believe COVID's real, right? They don't. And there's a mistrust that's deep rooted of authority. And this is why a lot of folks go to alternative medicine to begin with, because in the States, not everybody has access to healthcare, right? There's a great mistrust in certain communities anyway, right? So, he thinks that that's a level that it's at. And then if you start to look at this institutionally with like science education, and most people's scientific literacy, critical thinking literacy.
Yeah.
So anyway, so yes, I agree with you that it's become politicized because people are using it for their own political advantage. I absolutely agree with that. I do not see any compelling ethical arguments. There's no right that anybody can appeal to that I can, that's coherent, right? So I think that in the end, what it is that some folks, or the majority of these folks, when you're looking at their discourse, they don't believe that it's real, and they believe they're really into self-efficacy. Like they want to be able to find out for themselves, and they'll go to the internet and see the first thing or see what they believe because they think that they can do it. And that is like dealing with that kind of response is it's a very difficult thing.
And the major issue is that most of these people that refuses to take the necessary measures pick up the misinformation in the social media.
Yes, and that leads to other issues, right? Like this is all the way down. I see that, I see another hand up.
So hi.
Hi.
I'm wondering about this duty to communicate that you talked about during the presentation, and it seems like that's from the government perspective. There was a duty to communicate and be transparent, and it seems to me that there were some problems with that at the beginning of the pandemic, and some discussions of things in more absolute terms than we knew scientifically. Do you think that played a role?
Oh, absolutely, right? And again, I think it's also about literacy. It's like people have a really hard time, I know I do, it took me a while, to think about probability. Like we're really easy to understand absolutes, like all the time, none of the time, right? But probabilities are very difficult for us to understand. And you see this with people who argue all the time. If you can have like one counterexample is like, well, see, it's not totally true. And you're going, well, nothing's totally true. The only thing that's totally true, and this is philosophy talk again, the only thing that's totally true are tautologies, right? Like a bachelor is an unmarried man is totally true because it's true by definition, or the truths of mathematics are totally true. Everything else is probability, right? Everything else is, 9 times out of 10, it's true, or, whatever. So there's always a possibility. So what I teach students is I say, look, there's a distinction between a logical possibility and probability, right? And then probability, this is about risk, right? And this is about how much risk you are willing as an individual to take. And what we know from our friends in social science is that we're really all over the map with that. Some of us are really risk averse, and some of us are totally fine to take risks, right? But to even articulate what that is, we're not even there, right? And another thing, and it's something that we've had discussions before, and you pointed it out, and I forgot to mention it in my presentation when we're talking about communication, and especially on the equity line, like there is mistrust. There's huge mistrust, and there's mistrust for a number of ways. So we were talking about the scientific mistrust, or the just people who mistrust the government just because, and there's people whose mistrust is developed through ignorance, and not having a good understanding of like facts, and how facts are made and what science is and stuff like that, and the idea of certainty about risk aversion. But there's also those folks who just won't even bother to go, like, how do you get them on board? And so you were mentioning something about in Las Vegas, like community organizations going door to door, right? Asking if people have been vaccinated yet in their community, like in tighter communities, and then, and having conversations with them about why they're vaccine hesitant, because there's lots of different kinds of folks that are vaccine hesitant for lots of different kinds of reasons.
Any other questions? I don't see any other questions, Dr. Gillis. Thank you so much for such an incredible presentation. Dr. Gillis will be back with us on December 9th discussing the value and importance of arts in healthcare.
A very different kind of conversation.
Yes.
Look forward to it.
So please join us on December 9th.
Happy and beautiful.
Let's just give one more minute to see if there are any other final questions. We wish everyone a very happy and healthy Thanksgiving, and we'll see you in December. Thank you again, Dr. Gillis.
My pleasure. Thank you very much for your attention.
Good night.